Is it my presentation on the screen?
Yes, okay, great.
Perfect. So good morning, good afternoon to everyone. It is a pleasure for me. I'm really feel honored to be invited to talk about the low-cost medical thermography and instruments for the practical application in real clinical settings. As Dr. Brioche introduced me, I am Dr. Rafael Bayareh-Mancilla, which this is one of my lines of researching. So let's get into the problem that the diabetes, at least in Latin America, the prevalence and impact is that at least 1 of 11 adults between 20 and 79 years in South and Central America have diabetes. And this is also expected to increase by the half of the population by 50 million by 2045. So another burden between the diabetes is that undiagnosed cases, around 1/3 of the people living. It means that still there is some universe of the population that still we don't know if they have one kind of diabetes. And this is also a very big problem because they cannot access or they're not aware about several complications. Regarding the mortality, this is responsible about 410 millions dead, at least in 2021. And between the children and adolescents, around 121,000 children and adolescents at least were diagnosed with diabetes type 1. Regarding the healthcare and expenditure, these have cost in our region about 65 billion in 2021, and not even mention about the hyperglycemic pregnancy that one of 6 mothers, which babies are affected with hyperglycemia and pregnancy. In such case, how are our statistics in our region? We can find that Mexico and Brazil leads in Latin America with people with diagnosed with diabetes per million. However, observing the percentages, Brazil have more population diagnosed, but it is regarding of the quantity of people, density of people in Brazilian territory, respect with Mexico. It means that Mexico have more prevalence of diabetes in our society due to several factors. Even some discussions are due to our genetics and lifestyle and also diet. So in such case, our motivation and hypothesis is that given a diabetic foot complication that can lead to severe health issues and lower limb amputations, we can also maybe research for a way to get an early detection for preventing adverse outcomes, even the worst one is death. And so we try with thermographic equipment that offers a non-invasive, cost-effective, and efficient method to get early detection. And of course, at least at this moment, it is not recognized by the FDA. However, this is a very strong motivation because for the different research groups, this is a racing to get this method and techniques recognized. So our hypothesis is around that given temperature differences on the foot can indicate early signs of diabetic complication. So if we can offer a technique that which we can monitor in a regular way these variations, maybe we can help to identify and address different issues before they get escalated. Can be some surgical procedure, just an amputee of the foot, amputee of the lower limb, etc. And some early intervention can also reduce complications and improve patient outcomes, at least. So in our medical context and perspective is that most of the, or even the half of the ulcers can occur in the plant site. And some of them even can go unnoticed before the first check with the medical group. So the hypothesis that we use thermal thermographic equipment is that in a normal view of the human, we cannot see with our eyes temperature differences. So with these sensors that are shifted in the infrared spectrum, we can see different temperatures, not only in the plantar side, but also compare in a regional way the temperature between left and right foot. So we can detect several temperature differences in which we can, with algorithms, predict that if this specific patient, this particular patient, can develop some kind of complications such as diabetic foot, ulcers, etc. So these automatic temperature differences that we can compute can only show possible in a plantar site. How is the situation given the diabetic foot ulcers in our region, at least in 2021, regarding the International Diabetes Federation? Is that it is estimated in a ranging of 6% to 81% different studies have been detected in Latin America. And about the lower limb amputation, still there is no any statistics that leads to a particular number, but it is well known that it's not decreasing in our region. This is given most of the times by a peripheral neuropathy, that our prevalence in South America range from 6 to 81% in the general population with diabetes, and arterial disease still has a prevalence between 20 and 55%. This also means or leads to the hypothesis that approximately half of the population that have diabetes will lead to a peripheral arterial disease. So what's about our research line? Our main objective is to study the effects of thermal distribution given to vascular problems in a diabetic foot. Complications can be for a early detection, or also to help in the not only in the diagnostic but also in the medical healthcare after the diabetic foot is diagnosed. So our goal is to detect early stages of these complications, prevent foot or lower limb amputations, and also reduce the risk of death in very severe cases. In such way, we develop low cost equipment because at this moment the thermograph cameras are expensive, are higher in cost, and we know as scientific that resources are very limited also in our region, which is Latin America. So we program in the embedded system, more specifically Raspberry Pi computers, in which we introduced microbolometer arrays, which is a very low resolution camera in terms of resolution, spatial resolution, but at least we can detect a 1/10 of degree with this bolometer array. So we can also characterize these cameras to live to measure temperature in skin. It means we use superficial thermographical studies. In such way, in the first approximation we did at the beginning of our research was to characterize these sensors, in which they are so small compared to a quarter of dime of a dollar. So we research for some kind of phantoms. Phantoms, it means is a body with very specific physical characteristics. So we try to emulate some kind of a black body with a skin thermal characteristics. So we could change or vary the temperature in two different phantoms. So in order to compare it, we can get a characteristic equation only for these kind of sensors. Later, we knew that we could improve this equation which is embedded in the code in order to retrieve a temperature in degree Celsius range, in such way that we fix the conditions in a better place, in more controlled environment, and apply also different approximations. In this case, we presented a neural network in such a way we got a linear regression and improve this equation so we could reduce also the error or the tolerance in which we measure the temperature, because we should remember that in thermography measurements and studies, the temperature we are retrieving is not absolute, it is relative. Most of the times can be relative to the hottest spot that is detected within the spatial resolution of the camera, or even sometimes can be opposite, is the coldest spot. So also we have registered a patent in Mexico about our equipment, which is as a quantification thermical system for detect regions of the sole of the foot for diabetic foot complications. Later, once we develop the first prototypes, we start to replicate some of them. We got at least 3 replicas of our prototype. So we start to study some patients. It means we escalated now research into clinical in the clinical environment, in which Daniela Cabrera helped us in her master studies to retrieve information specifically with people with diabetes, but not with diabetic foot, and diabetic foot with also people that has diagnosticated the diabetic foot complication. In such way, at this moment of our research, only we have retrieved the data, but still we are working to condensate all this information, not only images, but also Cabrera retrieve information about blood pressure, blood studies, um, gender, ages, etc., to create a database to find some correlation not only with the thermographic images and data, but also with prevalence of ages, gender, region, and the data that can be retrieved from blood studies. So for the clinical studies done by Cabrera, the target population was people only with diabetes type 2, because it's the most prevalent in the Mexican society. And well, of course, they had signed an informed consent. The study group has no complicated diabetic patients, and diabetic foot detected. The equipment was a clinic vital sign monitor, a measurement of this molecule, and the glucometer in the understanding that patients had 8 hours of fasting. The classifications was based on Wagner classification from 0 to 6, and the inclusion criteria was only adults diagnosed with diabetes type 2 and some complications with treatment. And exclusion was if there was no any patient who was not agree with the consent. And the standard, of course, is the same standard we always use in the clinical area, and the database until this moment we have it saved, or we keep it in our database as an Excel data digital book. So now, what is in the frontier of our state of art in our laboratory is that now we are trying to classify with machine learning, but also predict with deep learning if some patient will develop some kind of complications, specifically diabetic foot. And we have also worked in a semantic infrared segmentation, because sometimes we can get some kind of thermal interferences that is not desirable in our studies, because this can produce error also in the classification stages. And also we are working in a generative artificial intelligence to increase our database image, because something ironic that happened to us as a research group is that even Mexico, we have a very big population that are diagnosed with diabetes. Still, we cannot retrieve enough images and information to carry out a study, which cannot lead um, a wrong prediction or a wrong classification due to a phenomena that it's talking about when a system can be uh, over predicted. And finally, we are also studying thermal pattern recognitions. So not only because we are interested to compare left and right food in order to get some differences of temperature. Some literature says that differences temperature of 2.2 degree is also indicative that there is a peripheral complication, but also if we can find spots that may lead to future ulcers. Also, we have work in 3D thermal reconstruction. Here is a prep line which I work in my doctoral studies, in which we fusion bimodal images. I mean, we used equipment in bimodal in the visible spectrum and infrared spectrum in such way that we can retrieve 3D modeling so we can introduce to the medical or oncological researching group not a collection of different images, but also only one entity in which they can manipulate to observe in different points of view. Because also we are aware that the ulcers, they are not only can appear in the sole of the foot, but also there are other kind of injuries that can be uh, developed in another areas of each lower limb. And also we are working in 3D reconstruction and modeling with multiphysics based on a finite element modeling. So we are interested in how is the thermal distribution between diabetic foot and non-diabetic foot, and also healed patient with versus with diabetic patients, so we can understand better not only where the ulcers can appear due to biomechanical walk studies when somebody's walking, the kind of shoes they are wearing, etc. But also how is the this thermal distribution regarding to vascularization problems. So some of our lasted research, we have also used multi-layer models in which we can consider bone, fat and skin tissues. So the thermal distribution can be leading to more approximately realistic simulations, and also how the ulcers can have different distribution, given that sometimes these thermal differences can lead to early diagnostic of any ulcers. So our conclusions from our research team is that we are aware that effective thermographic image processing can lead to an effective identification of early signs of these complications, providing by a non-invasive method for monitoring and diagnosis. Also, because we are working in 3D modeling, our modeling based also not only in thermographic but also computational tomography can give us a better understanding of temperature distribution, maybe vascular problems in diabetic foot, and so maybe also can give a better diagnosis and treatment planning. And now that artificial intelligence is very attractive research line, we are trying to study in a way that can we retrieve a data augmentation with a generative technique. So we can increase and also the increase and give a diversity of images to make better, to improve our systems, also not only in classification, but also in prediction, and in such way that we can improve with diagnostic tools for the medical community. And finally, the integration of multimodal data, that not only we should use infrared spectrum images, but also clinical recordings and visible spectrum, such as normal cameras, to create a more comprehensive model and early detection monitoring for diabetic foot conditions. Lastly, I would like to thank to the American Association Thermography for this invitation, and our research group at this moment that uh, is integrated by Garduño Aguirre, which is a student in pre-PhD in CINVESTAV, and my mentors, Dr. Lorenzo Leja, which is a research professor, as well as Dr. Arturo Vera Hernandez, both of them professors from CINVESTAV, and I am actually also a research professors, but I am in the UPITA, which is one of the schools of the National Institute, National Polytechnic Institute, and three of us, we also belong to the National System of Researchers. So thank you very much. Here is my email. If there is any further questions or any further requests for collaborations, of course, we are pleasure to listen or to read you in further communications. Thank you very much.
Thanks so much, Rafael. Congratulations on your outstanding work. It's amazing. Your research stand out for introducing an innovative approach to thermographic analysis of diabetic foot complications, especially with 3D. The 3D, I love it. This why I was studying your research and I'm very interested, and I'd like to share this with the other members here.
Yeah.
While 3D thermal modeling has been extensively explored in breath thermography, applying it to diabetic foot and maybe in future ulcer risk assessment, is remarkable and much needed contribution to the field. So I like this idea. And one of the most impressive aspects of your study is the use of the oblique thermal image. I like that you not show only the solid, but the little oblique, and it's
Yeah.
possible to see the veins on that image. So it's very creative that, and I try to do some image similar to that, but I believe you did this because you're studying the 3D modeling, and I would
Yes.
like that you confirm it with me if it's true. Because when we have a 3D, it's not good to have a so plain image, so it's better that you have the where is more close to the camera or the place are more deep, and I like so much this. But about the bidimensional thermal imaging, don't you think it's very important to start with the bidimensional first and after go to 3D, or do you believe it's no don't need now? You are so advanced that with 3D you can
Mm.
grow on this AI approach and to discover how to predict the risk of ulcers.
Yeah, totally agree. I think that the problem can be solved from a spatial image, a 2D image, because at least oncological specialists just only need a single view, right? No matter if it's from the sole of the foot or the obliqual image, or even a picture of a image from another region of the lower limb. Of course, I am totally agree that the solution can be from only a 2D image. And also the EA approaching needs 2D image. They don't need a 3D model. However, the motivation for exploring the 3D modeling is, I think, a very future perspective in such way that not only we can give a collection of images when we are monitoring a patient. That is a problem because a long monitoring, sometimes in years, can lead to several images that the medic, the doctor, has to inspect sometimes one by one. So maybe the idea is that given a collection of images during a large stage, a large period of time, that we can get only just a 3D model that can have a evolution regarding the time. So the doctor can only inspect this as an entity and know that some months ago this patient had a very characteristical thermal distribution, but given a good treatment, a good following, the thermal distribution had changed, leading to recuperation. So
Mhm.
that's the hypothesis of 3D modeling, but of course, I am totally agree that the problem can be solved uh,
Mhm.
with a 2D image.
Very good, very good. I have many questions here, but to share some ideas. And one of them is about the formula, and I like so much. And the formula you presented is quite interesting. The formula for calibration the thermal camera, and this is you use only on your paper for your camera, or can it be used to calibrate any thermal cameras? For example, most of time we have some doubts if we are really measuring, uh, if the camera is really showing the right measurement to us in some situations. So I would like some tips from you, or how can we do something similar, or how can we adjust our cameras on this situation? For example, you do the image, you see that it's not zero or not 0 degrees, and it's possible to adjust on the camera in the emissivity. Do you think it's possible to do this also? I don't know if it's, was clear on my question.
Okay, this equation, this model was specifically conceived for the sensor which are lepton 2.5 and lepton 3.5.
Uh-huh.
However, we calibrated these sensors because especially lepton 2.5 is not calibrated from the company.
Mhm.
3.5, yes, but it is not calibrated for measure specific materials. We
Mhm.
should remember that in the thermography researching, the skin is very similar to a black body in terms of emissivity. It
Mhm.
means we are the skin can absorb in 98% the infrared radiation. It means that if we calibrate, we characterize these sensors with a black body that is almost remember by definition a black body has an emissivity of 1. It
Mhm.
is a rate from a number going from 0 to 1, in
Yes.
which it is like the name says is a black entity which will absorb completely the infrared radiation. So here in the images we can see two cables that we also characterize with the thermocouples that were introduced into this black body, and we change the temperature in a very controlled environment. So we compare a camera. The model is a Fluke TA32, which is also calibrated from the designers. It's by the it's coming from the manufacturers. It's also calibrated, and then we compare it with these sensors, lepton 2.5 and 3.5, in order to retrieve these equations. So regarding the question, is this model applied for any camera? No. It
No.
depends of the microbolometer resolution.
Mhm.
It's also depending of the spatial resolution and also depending of the distance of our patient, or in this case, our black bodies in which we calibrated.
Mhm. Very good.
Yeah.
And
Uh,
the shielding panel you use it for foot imaging appears well designed. I like so much when you isolate only the foot. And what material was used for its construction? Basic question, like
oh,
it's good to know. Was it chosen for any specific thermal properties? Yes, this and the black one I saw on the other image. I think it's the same material.
yeah, the background we use a material is just a foamy. It's just a sheet of foamy.
Mm.
and
Oh,
so we cannot get thermal interferences around the food. No, that's very important. Also, we apply the same idea with the in the clinical studies
mhm.
because sometimes we can see that the hair, the hands are of course they are hot and they will give some thermal interferences. So we use this kind of material, and also we use some techniques we use for reconstructing a 3D model with a co-registration based on SIFT, in which we correlate each of the points of the foot, and then we use only the infrared image as a warping method, like a warping paper for the gift. We did the same. So we retrieve first the 3D model in the visual spectrum, and then we cover this model with thermographic images with the ER, which is the rainbow mapped. That's why some models can lead to errors like here, that the fingers were not well wrapped with
Mhm.
the images. But also we're exploring because at the time of this researching we use SIFT. Also we try with the SORF method, but we could not get a proper co-registration between consecutive images.
Mhm. And
Yeah.
show again that slide with the woman laying down, and there's something interesting on that. Yes, here, uh, here you just are you capturing the real temperature on this moment, or is just an example how to capture the 3D image?
For this patient, we didn't capture a 3D because we have to do it side by side, and still we didn't have a clinical trial for 3D modeling. But
Uh,
this one was only for detect the temperature differences between left and right. And yes, the temperature we are detecting is in the moment.
because
So some of them were they back in different sessions for following, but that is a very big problem we have in our research, or maybe even in Mexico, discussing with another colleagues that the perseverance of the patients is not constant. So maybe we can do a follow up in 1 week, 2 weeks, and then they disappear for some reason. There is no correct following up situation in our society.
Mhm.
So only we are restricted to take images which capture the temperature in the moment of the study, and we are not aware if next week, next month will change, will be better, will be worse.
Okay, because on this image we have something interesting to discuss, and a little word, the fact the patient is wearing clothing during the analysis. So most of time we imagine that could this have influenced the plantar temperature readings by retaining heat, understand? So if she has much clothes, maybe increases the temperature of the feet, something like that. And do you will you control this in future, or you're not so worried about that? So how was this controlled in your study? Only the room temperature, or and no need to expose more the patient during the um, when you capture the image?
Yeah, that's right, and I am totally agree that the patient that is wearing clothes can also lead to retain the temperature. In our protocol, we propose first the camera should be at least 30 centimeters far away from the sole of the foot, and wait 15 minutes for temperature stabilization with the environment room temperature.
Thank you. Go ahead, Sergio. Please, Dr. Sergio has a question.
Hi, morning. Congratulations, Rafael, for all your work. It's amazing. Everybody working with in thermography, thermology, imaging, I think is futurist. for the next 20 years. And for your work, it's amazing. One question for your EA by thermologist, by inflammation thermologist.
Ask again, Sergio. We had a problem on internet, on your internet sign.
Sorry?
Ask again the question because your internet interrupted your question.
Okay, I shut out the camera from no lighting for thermal. Okay, again. Sorry. How your system between difference from EA by neuropathic patterns thermology from the inflammation patterns thermology imaging from EA?
Oh, still we are not at that stages. We are actually studying this situation with our student in the PhD stage. So the idea of applying EA at least in the stage of our researching group is just only for classification when a patient, an automatic classification when a patient has at least a differential temperature of 2.2 degrees. The way that we try to predict that if somebody could lead a peripheral issue answering this question is just to the same to lead to detect differential temperatures of the sole of the foot and also different patterns that can give in the sole of the foot because not always the food can lead to a homogeneous or a standard temperature, but sometimes some kind of patterns, figure patterns or geometrical patterns can appear. So that is our hypothesis, but still we are in a very, very early stage. I am so sorry I cannot answer properly this question.
Okay. Any question from anyone? Want to do a question, Elaine? If you want to do, could be in Spanish.
I guess Dalia wanted to ask something. See, Dalia, go ahead.
Are you listening me?
A little low, but it's okay.
How about now? Is better?
Better.
Okay. Rafael, thank you very much for all this knowledge. It's very interesting for us. And I have a question. It's about, have you considered providing this low-cost infrared camera technology for diabetic patients to monitor their own feet at home, like if they are participating in a remote diabetic foot assessment program or something like that?
Yes, of course, but that's in a long future perspective. The first way we are conceiving this technology, specifically in these images we can observe, is to provide it, but to the medical people, doctors. We think this prototype, we name it as a frontline dispositive. It means that this equipment is not only reserved to high-level hospitals, high-level clinical researching groups in a medical community, but also this can be found. I mean, the idea is that this equipment can be found in a normal clinical buildings, right? So that any doctor that doesn't require to be a specialist in the area can use this equipment, just a frontline device that can give a pre-diagnosis, and then a specialist can be introduced to give further diagnosis. But this is conceived for use for the medics or doctors. It means the users of our technology is for instance is just for doctors. Maybe yes, of course, can be used in at home, but the problem is to educate educate the patients to use it to not lead to thermal patterns or thermal images that can be due to thermal interferences. So educating the patients can be a challenge because it's just not easy, just like to take a cellular a camera, a phone, and take a picture. It's more than that. So that's a challenge. But yes, we have spoken about that idea, but still we are very far away. So we uh, reduce our users only to doctors, to medics. Yeah.
So as I understood, this program that you are developing, it has a main focus on the first screen of these patients, of this diabetic foot, for this diabetic foot assessment for the clinician. The general clinician can do this and then provide all the information for the patient and send them to a specialist. So it can be used in a remote places where there is a lot of technology for assessment. Thank
That's
you.
right.
Good
That's
idea.
right. That's
Thank you.
right. Yeah, that's right. In Mexico, we have these kind of governmental programs in which people maybe cannot access or they don't have easy access to medical services. So this equipment can be used, can be applied for these physicians, and even by internet retrieve the information to data servers, so they can be processed with EA or another methods. So in the moment or maybe even in real time, they can get an assessment.
Very good. So, I heard and I read that you also are make some research in breast cancer. And do you use this technology for the same research, for this other research?
Not yet. Regarding my breast cancer researching was a postdoctoral period in which we use only mammography images and apply artificial intelligence for segmentation, for classification, for prediction and BRAS classification, but still we haven't used thermographical images because we still are um, discussing about it because my postdoctoral studies were not made with the same research group, but now at this moment I have back to collaborate in this laboratory, so still we are discussing. But yeah, I'm sorry about this confusion.
No, it's okay. It's very nice. Thank you very much.
Thanks to you. Thanks.
Rafael, do you have any plans to test this technology in real clinical settings with larger patient cohorts? I saw that you are collecting many clinical parameters, HbA1c levels, neuropathy severity, vascular Doppler results. So we're expecting here many in the future some good results, isn't it?
Yeah, we are expecting. I cannot say at this moment if there are good results, but we are searching for correlation. But still, the lack of patients is a very big challenge for us. So we hope in the future not only improve maybe I may say the resolution of detection of temperature differences, but also the quantity of patients can be better for us because in thermography area, it's very difficult to find databases or even free access databases. I may recall about my research in breast cancer. It is more easier to find free databases of mammography than thermograph images, no matter the complication we are or the medical condition we are studying, diabetic foot, diabetes, breast cancer, arthritis, etc. In thermographic researching, the databases it is a challenge. So I hope in the future we can democratize our databases for improve the researching around the world. At the end of the day, the science should be universal. So our main challenge in this moment is the quantity of data, not only in terms of thermal images, but also different data such as the 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 chemical compounds in the blood, the gender, the population, etc. So yeah, I hope I cross my fingers that we may lead to good results.
And yeah, we have many things here for the future. So I recommended that everybody construct his one data base first, because sometimes you don't know how the images were collected and in which conditions. So to work with image that you not sure if how it was collected is something complicated. Sometimes, especially here on infrared imaging, where you need to do the right position, put it on the right temperature room, wait for the patient to thermalizing for the room temperature. So, but sure, it's important we have this data bank, but at the same time, we construct more one data banks. And other aspect very important is we have many opportunities here for the future. For example, it'd be very interesting to calculate the receiver operating characteristics, the ROC curves in future to measure the performance of thermal imaging, detecting early stage diabetic. It'd be interesting to enter in intra-hater reliability analysis to understand how constant we will be. So with these aspects, I believe we can have a good data basis for the future also, and keeping comparing the thermal patterns with the clinical parameters and growing on this direction. But
Yeah.
I'm very glad with that many people are studying diabetes. We have a lot of interest here in Brazil, as you showed in the beginning. We have a high incidence of diabetes patient, and in our last medical meetings, we have the opportunity of other professors from India. In India, they also have this problem, and we know that U.S. also have interest. So many nations have interest in early detection, and infrared imaging is open this opportunity with papers like yours. And so your work paves the way for major advancements in diabetic food diagnosis and the integration of biomedical engineering, AI-based feature recognition, and advancing statistical modeling with 3D. So all of this could significantly enhance its clinical applicability. In the name of American Academy of Thermology, I would like to thank you your presentation. For us, we had opportunity to talk with the research face to face, and it was very good. So if anyone wants to do any question, or so, Rafael, you can proceed with the final comments.
Yeah.
You can go ahead, Rafael.
Okay. Yeah, just it was pleasure for me. Also, some of my research are references by you, Dr. Bresci. So for me, it's a very big honor you have invited me for this talk and to present everything we have done, at least in a period of approximately 8 years since my studies in master. And it's all life in which I have a work, I have a study around thermology. And nothing, thank you very much to everybody. I feel very honored. It's a very big pleasure for me. So I hope we continue in contact in our group and continue discussing. Finally, feel free if you need, I share my papers. Feel free to write to me in our group, or there is my email. Nothing, thank you very much and have an excellent day.
Thanks so much, Rafael. And if you, I guess that your university has opportunity for people that want to do a mastering or doctoral. Is it possible actually to have some kind of orientation from you or from your group, someone that want to do research on thermography?
Yeah, of course, we are open doors. Also, the laboratory may be considered as international. We have received people from Portugal, Uruguay, Cuba, Spain, France. Actually, my doctoral studies, I made it a co-titulation between Mexico and France. So always we are open. We have open doors for receiving international students.
Okay, thanks so much. And this, so we finished our Saturday Medical Minutes, and see you on the next one. Thank you, everybody. Thank you, Rafael. See you on the next.
Thank you, everybody.
Bye.
Bye.
Have you heard what's happening every Saturday at dawn, where the brightest minds connect?